Okay, so today I'm going to talk about functional decline and aging and what we know about it and what we can do to try to either slow the decline or to age more successfully. I'm Lisa Roberts, and most of what I'm going to talk about today is actually research that I had a hand in. But first, we'll get some background information on what I'm talking about when I say functional decline and what happens during the aging process. So, in general, the aging population is vastly growing, and this is pre-COVID, and so COVID might be kind of throwing off some of these numbers, but it's really projected that by about 2050, we would have more adults over the age of 65 than we would younger children, so individuals under 18, which that population change is different than we've ever experienced in the United States before. And so we need to figure out how we can best serve this altering population demographics. And really, when we're looking at older adults, what we see in terms of disability across older adults is that the majority of disability is going to be in the mobility range. And so these would be things that are affecting walking, are affecting ability to climb stairs, basically to get around and interact in the environment. And then from there, other disability types that we see cognition is obviously one. And then we get into independent living disabilities. So being able to actually actively engage in your world and accomplish tasks that are important for successful living, and to be able to do that independently are also driving forces of disability amongst older adults or adults who are older than 65. And so when we think about what we can do to maybe try to limit that or minimize the effect of mobility-based disability, we have to think about the process of disability. And so really we can go through the pathology of disability, which leads to an impairment. Those impairments actually lead to disability that is seen. And then eventually all of that results in mortality. And when we look at this from a research perspective, pathology is going to be researched more in terms of chronic or acute diseases, genetics, behavioral interventions. And then for impairment, what we're able to measure are things like gait speed, so walking speed, balance capabilities, strength capabilities, and disability would be more of how those tasks transfer to engagement in our environment. So being able to independently live, dressing yourself, hygienic practices, things like that. And then at the end, we have mortality, which is really going to kind of surmise into longevity. And when we look at research, what we find is that gait, speed, balance, strength, these markers of impairment show effects that relate to these transfer tasks, so to the actual disability that we see. This gait speed is related to the longevity that we can see in older adults. And so really where we want to kind of study, where we want to intervene is at the stage of impairment, because that's going to directly impact the progression or the appearance of disability, which will then impact the mortality. And we can even see this across specifically gait speed, where we find older adults that have a higher gait speed, so just a better ability to move around at a faster pace, have a longer lifespan, have a better mortality curve or survival rate than adults who have a lower gait speed, and it's really well correlated within the research. So gait speed is kind of seen as an outcome measure that we can easily assess in research that's going to have an impact on longevity and survival in older adults. And so that's a little bit of kind of background on really what we're looking at and how we do that in research, but what's kind of causing this mobility issue, we can expand just a little bit more. And so with older adults, we see this marked change in physiological makeup of structures, but specifically skeletal muscle. And so we see this rapid loss of skeletal muscle, which is termed sarcopenia when it's related to older adults. And it's very fast. We start to see this loss of muscle size after the age of 30, and it's decreasing at about 10% decreasing by about 10% by age 50. And then after that, we have a further decrease of 1 to 3% loss each year after the age of 50. That's a very rapid loss of muscle mass. That can have effects across the body in terms of metabolism, but it also has huge effects in terms of just ability to perform tasks. And you can see in this picture, so what we're really looking at is a cross-sectional area of a thigh where the darker tissue is going to be muscle tissue. The white that's surrounding it is going to be fat tissue. And we can see that in the younger adult, there's a lot more muscle. When we get to that older adult, thigh cross-sectional is a lot less muscle, a lot more white tissue. And that tissue is not near as functional, and it doesn't actually help individuals get around. And looking at kind of what's contributing to that or what's causing that is incredibly complicated. This schematic is one of my favorite schematics that's out in the literature right now, because it shows the complex interactions between things as maybe simple as nutrition, but as complex as hormones or cytokines or inflammatory markers. And really, we see this interaction across the body of all of these different factors. And that makes this kind of difficult to study. So we're going to take a step back and focus more on what we can study easily, what's going to be shown or experienced in these outcome measures directly related to impairment or mobility issues. And so where it kind of began, this track of research, was with this study called the LIFE study. The study was completed in the early 2000s, I think around the end of the 2010s range. And it was this massive study that was across 8 different clinical trial sites. And the whole goal of the study was to look at a moderate intensity physical activity program and compare that to just a health education program amongst older adults. And they had almost 2,000 sedentary older adults, meaning older adults who were not actively engaged in any kind of physical activity program. And they followed these older adults for, on average, about 2.7 years, really following them to see how this physical activity or health education program affected their lives. Now, it's important to mention that this moderate physical activity program was only about 2 times a week of walking. Okay, and that's important just to think about in terms of how much physical activity we're really adding in an intervention like this. And the overall goal of the study was to look at mobility disability amongst older adults. And what they found was the older adults who participated in that moderate physical activity program, so twice a week walking, had less incidence of mobility-based disability, and which is huge because we think about if we can make people get around better, they'll have better health outcomes. And that was the thought. And so we kind of look, okay, well, what other kind of health outcomes do we want to specifically target? And one of those health outcomes that's of importance to older adults specifically is heart disease risk. Because as we follow individuals through the aging process, the risk or prevalence of heart disease increases quite drastically. And this is across both men and women. And so because we had this subset, this massive clinical trial study, we could compare within that, what were the incidents of cardiovascular disease? Did this physical activity program actually help prevent cardiovascular disease or affect it in any way? And really what they found when they looked at cardiovascular related events specifically is that twice a week physical activity had no effect on cardiovascular events. And so even if we just take older adults and we have them add extra walking, there was not a change in the incidence of cardiovascular disease or cardiovascular events. And that was kind of disheartening. And that's where we enter into the research that I actually have been a part of across this idea of where can we help prevent disability, but then actually see that affecting risk for other diseases. So with that information in mind, we know that physical activity alone was not enough to reduce cardiovascular events. We need to look at other factors. So when we were designing the study, we were looking at other factors such as sedentary time. So older adults are spending up to 80% of their waking hours sedentary, meaning 80% of their day that they are not sleeping, they are sitting on the couch, maybe sitting at their desk, watching TV, reading books, doing activity that does not involve movement. And so that's a huge amount of time that's spent sedentary. And this sedentary lifestyle is an independent predictor of coronary heart disease and mortality, meaning that sedentary life specifically is going to have an effect or have an influence on incidence of coronary heart disease. And if we can increase activity by even just 500 steps a day, there's a 10% reduction in cardiovascular disease risk. So with all of this information in mind, we want to know, okay, if I can reduce the amount of time that an older adult spends sedentary, can I improve their health outcomes, and specifically related to cardiovascular disease? So that's exactly what we did for a research study. In clinical trial research, we like to give nicknames to things. This nickname for the study was the ZIP study. And essentially what the ZIP study did was it took older adults and we divided them into two groups. One group was given a commercial-based pedometer or step counter, and one group was not given that piece of technology. Both groups went through a supervised exercise program that had walking for 30 minutes, and then 30 minutes of resistance training, both upper body and lower body, stretching exercises, as well as balance exercises. And they did this twice a week, and they did it for 8 weeks, both groups. The next 12 weeks following this exercise intervention, everyone was given the same goal for physical activity, but one group still had their fitness tracking device, and the other group did not have a fitness tracking device. And so we termed the group that had this fitness tracking device exercise plus NEPA. NEPA would be non-exercise physical activity. So we're just trying to encourage movement through technology. And then the other group was just the exercise group. They did not have this piece of technology, but they were given the knowledge about what kind of activity would be considered non-exercise physical activity. And we just let them go live their life for 12 weeks. At the end of that 12 weeks, they came back to our research site and we measured our outcomes. If we just kind of, this just breaks down who was in the research study. So we had a total of 40 participants, 20 per group. And this design, it was an intent to treat statistical analysis, meaning we included every piece of data that we could, regardless of whether or not the person was able to complete the study. That's important to note just because of sample size. So our primary results that we really found from this study was that the exercise plus NEPA group, so this group that had the additional piece of technology that told them how many steps they were getting a day, over the course of the 12 weeks where they were not coming to our exercise intervention, they had on average an increase of about 2,000 steps per day when compared to the group that didn't have this wearable technology fitness tracking device. That's a huge amount of increased steps per day, but that also shows that we really accomplished our goal of increasing non-exercise physical activity. So these older adults were moving more, spending less time sedentary. We also looked at blood pressure specifically, and blood pressure, because it is so related to incidence of cardiovascular disease, we really wanted to see, could we affect any type of actual physiological change? And in the group that had the wearable technology, the step counter, we saw that they had about a 10 millimeters of mercury reduction in their systolic blood pressure, which clinically, those values are huge. We were really excited about this finding because it showed us that we could actually change someone's risk outcomes or risk assessment for cardiovascular disease based on just increasing their non-exercise physical activity. So these are probably the two most interesting findings from the study. We did do, obviously, we looked at several other blood markers as well. And all of the other results from the study have been published. They're very easy to find in this paper, which is called Wearable Technology to Reduce Sedentary Behavior and Cardiovascular Risk in Older Adults. I want to point out on here that this is a massive team effort. It was not something that I did all on my own. And so I do want to give credit where credit is due with this list of authors that is on this paper. Everyone contributed greatly to this research project, but especially the principal investigator, Dr. Thomas Buford, at the bottom of that list. And then also, because it was a funded research project, it's important to acknowledge who those funding sources are. So this was largely funded by the American Heart Association. The research was conducted at the University of Florida, and then all of the analysis was conducted at the University of Alabama at Birmingham. And that is pretty much all I have to say. So thank you very much.